just tell you all the characteristic features of the first heart sound. So if you take the frequency of the first heart sound, it is medium to high frequency sound. Whereas you take the second heart sound, it is completely a high frequency sound. But whereas this is a medium to high frequency sound. And what is the duration of this sound? It is 0.14 second. And what will be the interval between M1 and T1? The interval between M1 and T1 is around 20 to 30 milliseconds. And the C point on mitral valve echocardiogram, it coincides with M1. Okay. And the downstroke of C wave of the LA pressure, even this also coincides with M1. And downstroke of C wave of RA pressure, this will coincide with T1. Okay. So C wave of MA pressure coincides with M1 and C wave of RA pressure, it coincides with the T1. So these are the characteristic features of the first heart sound. Now, what are all the various parameters which will determine the intensity of the first heart sound? See, these are all the parameters which will determine the intensity of the first heart sound. Number one, the structural integrity of the AV valve. What exactly you mean by this? It is nothing but, it is the thickness, right? It is the thickness and as well as the mobility of the leaflets. So these are the two things that will determine the structural integrity of the AV valve. And next important is the velocity of the valve closure. See, the velocity with which the valve closes, it completely depends upon the native position or the position of the AV valves. Right? That is the position of the AV valves. Like for suppose, if the position of the AV valves is like wide apart at the onset of the systole, then the valves, they close with higher velocity and you get a higher intensity sound. But if the position of the AV valves at the onset of the ventricular systole, if they are nearby, then they close with lesser intensity and thereby you get a soft S1. Okay. And the other parameter which will determine the intensity of the first heart sound is the status of the ventricular contraction. See, what did we discuss the mechanism of the first heart sound? It is the onset of your ventricular contraction. The pressure which will rise within the ventricle will determine the intensity of the first heart sound. Right? Now, if suppose, if the pressure rise within the ventricle is high, then you get greater intensity sound. But if the rate of pressure rise, right, if the rate of pressure rise in the ventricle, if it is less, right, rate of pressure rise within the ventricle, if it is less, then the valve, they close with lesser intensity and thereby you get a soft S1. So the ventricular pressure rise is very, very important. And the next is the physical characteristics of the vibrating structure. Right? What are all the vibrating structures here? Papillary muscles, chordae tendineae, then mitral valve leaflets. So this entire structure should be normal. Then only you get a normal intensity of your first heart sound. If there is any pathology in your papillary muscle or chordae tendineae or within the AV valves, then there may be alteration in the structure of your valve apparatus and thereby the intensity varies. And the other parameter is the transmission characteristic features. You see, the distance between the AV valves and as well as the chest wall is very, very important. If the distance between the AV valves and chest wall, if it is increased, the intensity with which you listen the first heart sound, it will be soft. Okay. So all this we will discuss now. Now, let me take up the discussion of the abnormalities of the first heart sound. So within the abnormalities of the first heart sound, like you have soft first heart sound, and there are conditions where you have loud first heart sound. Now, what are the conditions where you will have soft S1 and what are the conditions where you will have loud S1? All that we will discuss now. Now, soft S1, that means the intensity of the first heart sound is less. What are the conditions? Number one, if there is poor conduction of the sound from the AV valve to the surface of the chest. Now, what are the conditions where there can be poor conduction? Number one, obesity. So in obesity, what happens? There is increased soft tissue between the AV valve and as well as the surface of the chest. So the transmission of the sound will be reduced. So thereby you get a soft S1. Then you take in patients with the emphysema. So what happens in patients with emphysema? In patients with emphysema, you have large voluminous lungs, and these large voluminous lungs, they overlap the heart. And once these large voluminous lungs overlap the heart, the transmission of the sound to the surface of the chest will be reduced, and thereby you get a soft S1. Then in conditions like the pleural effusion, and that too, the left-sided pleural effusion, then in conditions like pericardial effusion, the intensity of the first heart sound will be soft because of poor conduction of the sound to the surface of the chest. Then decreased LV contraction. So the other parameter, what did I tell you? The pressure rise within the ventricle should be adequate to push the AV valves up into the atria, and accordingly your papillary muscles and chordae tendineae will pull the valve down, and thereby the vibration is being set, resulting in M1 and T1. If there is decreased LV contraction, where all you can have that in case of the mixed edema, that is in patients with the hypothyroidism. So in hypothyroidism, the LV contractility is reduced because the thyroid hormone levels are reduced. Then you take in patients with the cardiomyopathy. So cardiomyopathy is what? Cardiomyopathy, it is the disorder of the cardiac muscle. So if there is a disorder of the cardiac muscle, the ventricular pressure rise will be reduced, and thereby the vibrations which are set up within the valve is reduced, and thereby you get a soft S1. Then you take in patients with the acute myocardial infarction. In acute myocardial infarction, there is like pelvic dysfunction, or there is like left ventricular regional wall motion abnormality, because of which the pressure rise will be reduced. Once the pressure rise is reduced, then the vibrations which is being set up is reduced, and thereby you get a soft S1. Then you take in patients with the mitral regurgitation. So in mitral regurgitation, why there is decreased LV contraction? Because mitral regurgitation, at one point of time, the individual will land up in left ventricular failure. So thereby what will happen to your LV contractility? The LV contractility will be reduced in patients with the mitral regurgitation. So once the LV contractility is being reduced, the pressure rise is reduced, and thereby you get a soft S1. So this is about decreased LV contraction resulting in soft S1. Next, coming to your PR interval. Now, in which clinical scenarios of the PR interval you get a soft S1 is in patients with prolonged PR interval. Where can you have the prolonged PR interval? That is in patients with the first degree AV block. You will have the prolonged PR interval. Now, what exactly is the mechanism? Let me try to tell you. See, the normal PR interval is around 120 to 200 milliseconds. If the PR interval, if it is around 200 to 500 milliseconds, right, in the PR interval, if it is around 200 to 500 milliseconds, in this clinical scenario, the mitral valves which are open are minimal. There is less separation of the mitral valve leaflets. Okay, so once there is lesser separation of the mitral valve leaflets, whenever they are closing back from minimal area. So the initial position of the AV valves is very, very important at the onset of your ventricular systole. That is what we have discussed. And if the initial position is less, then the valves they close with lesser intensity, and thereby you get a soft S1. And whenever there is prolonged PR interval, like in case of the first degree AV block, there is lesser separation of the mitral valve leaflets, and that is what is resulting in the soft S1. Then mobility of the valve. Now, if the mobility of the valve is reduced, then the intensity of the first heart sound will be reduced. What are those conditions? Like in case of the severe calcification. So, severe calcification of the mitral and tricuspid valve. So severe calcification leads to calcified mitral stenosis. As such, you take in mitral stenosis, you will have loud S1. But in case of calcified mitral stenosis, the mobility of the valve will be reduced, and thereby you get a soft S1. So these are the conditions where you will have the soft S1. Now, the another important abnormality of the first heart sound is the loud S1. Now, what are the conditions where you will have the loud S1? Right. So, first and foremost, very important, that is in case of the tachycardia. So, in tachycardia, the LV pressure rise is high, and the ventricle is like hyperdynamic, which is contracting rigorously, and that will result in the loud S1. What are all your hyperkinetic states? So, all your hyperkinetic states, that will lead to tachycardia, where you can have loud S1, anemia. Then thyrotoxicosis. So just you should understand that in thyrotoxicosis, it is loud S1, whereas in myxedema, there is hypothyroidism, it is soft S1. Then beriberi, that is your thiamine deficiency. Then fever. Next, pregnancy. And the other condition is the presence of the AV fistula. Right, the presence of the AV fistula. And next is the Paget's disease of bone. Okay, so these are all the conditions where you will have tachycardia and the individual will have loud S1. Next, prolonged AV flow. Now, what are the conditions where you can have prolonged AV flow? That is in mitral stenosis and tricuspid stenosis. So, when the valve area is reduced to less than 2 centimeters square, we call it as mitral or tricuspid stenosis. So, whenever the valve area is narrowed, when the AV valve area is narrowed, the time required for the movement of the blood from atria to the ventricle is also prolonged. And during this prolonged flow, the valve leaflets, they are like widely separated. And there is a gradient which is created between the atria and ventricle. So, because of the increased gradient between the atria and ventricle, and because of the wider separation of the leaflets, whenever the leaflets, when they move to the native position, they hit back with greater intensity, and thereby you get a loud S1. That is, you will have loud M1 and as well as the loud T1. And next is the PR interval. So all the conditions wherever you have short PR interval. So what are the conditions where you will have short PR interval? Short PR interval means where the PR interval will be less than 120 milliseconds. So what are the conditions where you will have short PR interval? That is in patients with WPW syndrome and as well as the Longin-Levine syndrome. These are the conditions where you have the presence of the accessory pathways. So in these conditions, the mitral valve leaflets, they are like maximally separated by your LA contraction. So during the onset of your ventricular systole, the valve leaflets which are maximally separated, they return back with a greater intensity and thereby you get a loud S1. So please remember, in case of the prolonged PR interval, the valve separation is less. So when they come back and hit slowly and thereby you get a soft S1. Whereas in case of the short PR interval, the valves are maximally separated. When they come back, they hit back with greater intensity and thereby you get a loud S1. Okay. So this is about your PR interval story. Now, see, the questions can be in such a way correlating the ECG with the clinical scenarios. I will show you one of the questions. So, a 27-year male patient presented with the cardiac history of the atrial septal defect. ECG of the patient is as follows. What will be the abnormality in the first heart sound? Reverse splitting of the first heart sound, pathological splitting of the first heart sound, soft S1 and loud S1. Now, what exactly is the diagnosis of the ECG? If you observe it very carefully, the rate and rhythm and as well as axis are like more or less normal. But what is abnormal here is about the complexes in V1. That is, you have the presence of RSR dash pattern, right? The presence of RSR dash pattern in V1, what is it suggestive of? This is suggestive of the right bundle branch block. Now, whenever there is right bundle branch block, what happens to your T1? The T1 will be delayed. Why T1 will be delayed? Let me try to explain to you. So now if you see this image here, right? So this is the right bundle branch which is getting blocked. Normally what should happen? Both the ventricles, they contract simultaneously and thereby your mitral valve will close first and tricuspid valve will close later. Why is that? Because the pressure rise within the left ventricle is much more than compared to that of the pressure rise within the right ventricle, and thereby you will listen first M1, then followed by that you get a T1. And what will be the duration between these two? That is around 20 to 30 milliseconds. But in patients with the right bundle branch block, what happens is you will listen M1. That means the left ventricle will contract first. After the left ventricular contraction, the depolarization from the left ventricle will reach the right ventricle, and then later the right ventricle will contract. So the depolarization of the ventricles are not happening simultaneously here. The depolarization is like left ventricle is contracting first, followed by that you are having this right ventricular contraction resulting in T1. So thereby the duration between M1 and T1 will be more than 30 milliseconds. It is not 20 to 30. It is more than 30 milliseconds. So thereby, like what happens to your first heart sound? There will be pathological splitting of the first heart sound. Now let me discuss the splitting of the first heart sound. This splitting also, you can have like pathological normal split. What do you mean by pathological normal split? That means you will listen M1 then followed by T1, but the gap between M1 and T1 will be more than 30 milliseconds. That is a pathological normal split. Then you have what is called reverse split. What is reverse split? You will listen T1 first, then followed by that you will listen the M1. Now what are the conditions where you will have the pathological splitting, but it is M1 followed by T1, but the duration between these two is more than 30 milliseconds. So just now we have discussed one condition, that is in patients with the right bundle branch block. And the other scenarios are like related to LV, that is LV ectopic beats, right, and as well as the LV paced beats, right, LV ectopic beats and as well as the LV paced beats, right. In case of the LV ectopic beats and as well as the LV paced beats, what happens is the left ventricle will contract first, then followed by that the depolarization of the right ventricle occurs, thereby the T1 will be delayed, okay. And other condition where you will have the split between M1 and T1 will be more than 30 milliseconds is in patients with the Epstein's anomaly. So in case of Epstein's anomaly, like what happens is there will be atrialization of right ventricle, right, atrialization of the right ventricle. So the right ventricular cavity will be reduced and it will be hypoplastic. So what will happen when the right ventricular cavity is reduced and when right ventricle is slightly hypoplastic, the RV pressure rise will be reduced. Once the RV pressure rise is reduced, then the T1 what you get will be slightly delayed. So thereby the distance between M1 and T1 will be more than 30 milliseconds. So these are the conditions where you will have a normal splitting, that is M1 and T1. But the only thing is the duration between M1 and T1 is more than 30 milliseconds. So that is what is your pathological normal splitting. Then pathological reverse splitting, that means you will get T1 first and then followed by that M1. So where will you have this? You will have this in patients with the left bundle branch block, in patients with RV paced and RV ectopic beats. So in these RV paced and as well as RV ectopics, like right ventricle will contract first and thereby you get T1, followed by that the left ventricle will get depolarized, thereby you get M1. So that is one condition, that is RV paced and RV ectopic and as well as left bundle branch block. The other scenario is in patients with the severe mitral stenosis, right? Severe mitral stenosis in the sense where the mitral valve area is reduced to less than 1.5 centimeter square, or like it is very severe means the mitral valve area is reduced to less than 1 centimeter square, and even in patients with the atrial myxoma. So these are the conditions also where you will have the reversal splitting. Let me try to explain to you the mechanism in the severe mitral stenosis. See, in patients with severe mitral stenosis, what will happen is, let us just assume very severe, where the valve area is reduced to less than 1 centimeter square. When valve area is reduced to less than 1 centimeter square, what will happen to LA to LV flow? So LA to LV flow will be grossly reduced, right? LA to LV flow will be grossly reduced. So once your LA to LV flow is like grossly reduced, so the LV pressure rise, right? The LV pressure rise is decreased. So the LV pressure rise because the volume of the blood which is coming into your LV is reduced. So your mitral valve being stenosed, it is taking more time for the LV flow also from LA to LV. So once the LV pressure rise is reduced, and how much it will be reduced here? The LV pressure rise is reduced to such an extent, it is reduced lesser than that of your RV pressure rise. Normally, in a normal individual, the LV pressure rise is much more than compared to that of the right ventricular pressure rise. But in case of severe mitral stenosis, the RV pressure rise will be much more than compared to that of the LV pressure rise. So you will have the T1 first, then followed by that you will have M1. This will result in what is called the reversible splitting. And same story is even in your atrial myxoma also. See, in patients with atrial myxoma, what will happen is, it is the tumor which is originating from the interatrial septum. And the tumor which has come up from the interatrial septum will overlap the mitral valve annulus, right? Or it will overlap the left ventricular inflow. So, once this atrial myxoma overlaps or obstructs the left ventricular inflow, what happens? The amount of blood which is coming into your LV is reduced. So, thereby, your LV pressure rise is reduced much more than that of the RV pressure rise. So, same story here again. Okay, so RV pressure rise will be much more than that of the AV pressure rise even in case of atrial myxoma. So, thereby, you will have T1 first and then followed by that the M1. So, this is about the conditions where you will have the reversible split. Now, I'll just show you one more clinical scenario in ECG and you just tell the answer here. A 45-year female presented with syncopal episodes, angina and as well as dyspnea. His ECG is as follows. Right? What exactly is the abnormality of the first heart sound? Reversible split of the first heart sound, pathological split of the first heart sound, soft S1 and then the absent S1. Now you should be able to identify the ECG. So what are the abnormalities here? You see the QRS complexes, there are wide QRS complexes. And the another important abnormalities that you are able to make out here is, you are having a deep and wide S wave in V1 and you are having broad R wave in V6. So, deep, broad S wave in V1, broad R wave in V6, this is suggestive of left bundle branch block. So, whenever there is left bundle branch block, right, whenever there is left bundle branch block, what happens? The right ventricle will contract first. Because the right ventricle contracts first, you will have T1 first. Then followed by that, left ventricle will contract later. Right? Thereby you get M1. So you have M1 followed by T1. So what is this called as? This is nothing but it is your reversible split of the first heart sound. So remember, in right bundle branch block, you will have pathological normal split, that is M1 and T1, but the duration is more than 30 milliseconds. But in left bundle branch block, you will have reversible split of the first heart sound. Okay. So this is about the abnormalities related to the first heart sound. Now let me just give you a quick review of all the abnormalities of the first heart sound. So, right, you see this image here. That is the conditions where you will have loud S1, mitral stenosis, that in patients with the aortic myxoma, right, mild to moderate aortic myxoma, mitral valve prolapse, hyperkinetic states, and as well as the exercise, right? And other conditions like short PR interval, the other abnormalities you have. Then you have conditions where you have soft S1, that is in severe MR, severe AR, then calcified MS, LV aneurysm, acute myocardial infarction, cardiomyopathies, and then left bundle branch block. So these are the conditions where you have soft S1. Then what are the conditions where you have variable S1 that is mainly associated with the atrial arrhythmias, like atrial fibrillation, atrial flutter with variable AV block, atrial tachycardia with varying block, ventricular tachycardia with AV dissociation. So these are the conditions where you will have variable S1. See, why do you get this variable S1 in the complete heart block or in patients with atrial fibrillation is because ventricular pressure rise will be variable. Why ventricular pressure rise is variable? Because in atrial fibrillation, the impulse which is coming from atria to ventricle is not regular. It is irregular. So there is irregular pressure rise within the ventricle. So once there is irregular pressure rise, accordingly, you will have irregular mitral valve closure or tricuspid valve closure, and thereby you will get a variable first heart sound. Okay, so atrial fibrillation, atrial tachycardia, atrial flutter, all these conditions you will have variable S1. Then the other condition is that is split. You have wide splitting in patients with the right bundle branch block, LV paced beat, LV ectopic beat, then Epstein's anomaly and right atrial myxoma. Then where you get the reversible split? The reverse split you will have in case of the left bundle branch block, RV ectopic, RV paced beat, and as well as the significant mitral stenosis. So these are the conditions where you will have split, wide splitting and as well as the reversible splitting. So this is about the abnormalities related to the first axon.
Subscribe and press the bell icon so you never miss an update from PrepLadder.